What's up, guys? Before we get started on this episode, I want to say a big thank you to our partner, Hoya Vision Care Canada, for supporting us with this conversation. And this episode is actually part of a series of 4 interviews that we are doing on the topic of myopia management. This is the 3rd one. So once you're done listening to this, go back and listen to the first and the second one. There's different types of conversations that we're having. Some of them are about introduction into how to get started clinically. Some of them are more expert level practice kind of conversations and pearls. And this one here with Debbie Jones is going to be clinical, but also research-based education types of topics. She's going to share, what's going on in the research world in myopia management. So this is episode number 3, and make sure you look out for episode number 4. Once again, thank you to our partner, Hoya Vision Care Canada. And now to the episode. Hello and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harbir Sayan. Thank you so much for taking the time to join me to learn and to grow. I'm so grateful that you would take the time out of your busy day to join us here. I know everybody's got so many things that they could be doing. So the fact that you're listening to this or watching this right now means a lot to me. And thank you so much for all your support. It's been 4 years now since I've started the podcast. I can't believe how much it's grown, and it's all because of everybody's support, listening, watching, and sharing. And as always, I'm going to make the same request as I always do. Please share it, and please leave a review. If you haven't heard me say this already, recently we had a little glitch on Apple Podcasts, and all the reviews disappeared, and I don't know how to get them back. So we're just asking, if you wouldn't mind, please leave us a review and star rating, hopefully 5 stars. And that'll just help us get in front of more of our colleagues and share amazing conversations like this one. And this is a really special conversation. I have a very, very special guest with me, Debbie Jones, who is one of the most well-known names and faces in the space of myopia management in optometry in North America. And I'm so glad to have her here. Dr. Jones is a clinical professor at the School of Optometry and Vision Science at the University of Waterloo. She's the lead clinical scientist at the Center of Ocular Research and Education, which is CORE at University of Waterloo. She was recently a recipient of the President's Award from the CAO for her work in myopia, and I was grateful to actually be there in the audience there when she received that award. It was a great event. And also, she was the recipient of the Garland W. Clay Award from the Academy of Optometry for her work on the 3-year data of the MySight study. That award is given to authors of the study that is the most cited in the previous 5 years. So that tells you how much Debbie's work has been cited and read and shared. And it's amazing to have you here, Debbie. Thank you so much for joining me.
Thank you. That was quite the introduction.
Well, that's, yeah, that's shorter than it definitely could be a lot longer, to be honest with you. But wanted to make sure I got at least some of the key points in there, just for those few people who might not know who you are. So, truly grateful to have you here because, I've been watching from afar. I've seen a lot of the work that you do, and I see the impact that you're making on the industry. And you certainly are one of the most impactful people in the profession. So I'd love for you to share a little bit, if you don't mind, from your perspective, an introduction to Debbie Jones and who you are and what you do.
Oh, well, I think the first thing about me is I'm a clinician. So, I came from private practice way back when. I've been at the university for 25 years now, and I moved to the university, to academia from private practice. I did some teaching in the UK, but my main job, if you like, my main role was seeing patients. Particularly pediatric patients. So I really had an interest and a focus on pediatric patients. When I moved to Waterloo, I just continued that. I took an active role in the pediatric clinic, and that has naturally lent itself, of course, towards myopia control. I've been fortunate enough to do my research through CORE and to be involved in some pivotal studies. So again, in the MySight space, particularly working with children, and really it's just grown from there. So I think I come at things from very much a boots on the ground clinician perspective, which I think sometimes just gives me that little bit more credibility because I am actually seeing patients as well as doing the research behind, the theory behind myopia management and some of the products that we have. So that's kind of who I am. I mean, my day-to-day job is working with students, training the next generation, seeing patients, doing research, and everything else that goes with an academic job.
That's amazing. I think that's actually a really important distinction to make, that you do, not only have you had previous clinical experience, but you are currently in the clinic, seeing patients, the boots on the ground, like you said, because it is possible to be in the just this strictly the academic sphere and lose a little bit of touch with what's actually happening in the clinic. So it's really good to hear that. Now, we obviously are going to be talking about myopia management here, a lot about myopia in general. One of the statements that seems to be kind of growing in popularity or being shared more by experts in the space is that we need to make myopia management the standard of care. If it isn't already, but that should be a goal of ours. Now, if you don't mind, why do you think that is so important right now?
I mean, that's a great question. And really, there is no excuse for it not to be standard of care. We have so much evidence. We know the risks of myopia. We know the long-term risks. We know the ocular health risks. We have fantastic evidence-based products that are available to us. I mean, in Canada, we're blessed that we have the whole spectrum of products. And so I would almost turn it around and say, why would you not? You know, I think you'd have to have a really good reason to not manage your myopic patients the way we know they should be managed. So, I mean, Canada has really gone out on a limb and said, yep, we are, we've stated, or the CAO has stated, myopia management is standard of care. They've followed the WCO recommendation. And I think, you know, it would be wrong not to. It's a no-brainer, really.
Yeah, I would agree with that. And almost from the perspective of, if we're not doing it, we are potentially leading our patients to, I want to say harm, but it's you're you know, ultimately we know what the effects of not managing myopia are, right? And to then choose not to do it is almost ethically incorrect, I would say, at this point, right?
Yeah,
So
you're basically
you're right.
not doing the best for your patient. And as an optometrist, as any healthcare provider, your duty is to do the best for your patient.
Yeah.
Following the evidence and do the best that you can.
Yeah. And of course, there is a lot of evidence now. There's more than enough evidence for hopefully to convince even the most cynical. Speaking of, let's talk a little bit about the research side of the work that you do, because I think this is something that the majority of us, you know, our colleagues, we don't have a lot of experience in. I'd love to learn, what does that, you know, look like for you day to day? What type of research work are you doing? What's your involvement in that kind of area of myopia management?
So I have various aspects to research that I get involved in. The main one would be in clinical trials within CORE. So the MySight study, we were a site for that. We were the Canadian arm for that, and I was the lead investigator. And that obviously was a massive study. I mean, ended up being 7 years. So I was involved right from the get-go all the way through. We have other studies that are ongoing, looking at other types of myopia control, some of which, of course, I can't mention if they're ongoing studies.
Right.
Can't really reveal the too much detail, but I have been involved with various aspects of myopia control within the research space. I also do some research, some survey-based research, looking at what the public thinks about various aspects of optometry. So, you know, do they understand various terminology? And then I'm involved in this big study looking at a retrospective file review on what clinicians are actually doing in practice at the moment. So that's an ongoing study. We're just about wrapping up the data collection, and we just had some preliminary results actually at the American Academy meeting last week.
Very cool. Okay, so definitely want to put a pin in that, because that's going to be a question I want to ask you in a little bit, is what are practitioners doing right now, and, you know, what kind of goals do we want to set moving forward? So that's great that you actually already have some findings there that you'll be able to share with us, hopefully. I wanted to ask you about, when we are, as practitioners, evaluating studies, data, research that's coming out that, you know, various maybe companies are sharing with us, how do we evaluate that to evaluate the strength of it, you know, the validity of it?
Again, another great question. And I think objectively, you need to look at the study. You need to look at the number of participants. I mean, if it's an N of 2 or 3, you know, you don't have much strength there. So you want a good number of participants. And one of the really key things is looking at the impact on both refractive error and axial length. We know that axial length is really the key to myopia control and myopia management. It's that reducing the axial elongation is what we're really aiming for. So you want to look and make sure there's good correlation between axial length change and refractive error change. And we kind of got a little bit hoodwinked earlier on with some of the atropine work where there was an impact on refractive error, but not the same impact on axial length. I think we've almost come full circle with some of the atropine work. And I think the jury's out a little bit on the 0.01% atropine, but that's a whole nother podcast probably to discuss that. But I think look at the literature. And don't just take it at face value. Do a bit of a deep dive. And it doesn't mean you have to look at all the equations and all of the stats and all of the stuff that may just be complicated. Look at the actual values and the impact on both axial length and refractive error.
Got it. If we can take a little bit of go off on a bit of a tangent on atropine there, just for a moment. So I've been doing a fair amount of atropine in our clinic, but while I was down there in New Orleans, you know, I was hearing that perhaps atropine's not the best treatment option, or perhaps it's not what we thought it was. Would you mind sharing a little bit what you're just mentioning there about us coming around, understanding that better now?
Well, I mean, there's different studies that are being published, and I think there were two at the Academy that were mentioned that gave different opinions on the 0.01% atropine. You know, one study said, yes, there was a big impact of using 0.01%, and the other said, no, not really. I think there's different cohorts that they're using in terms of the ethnicity, perhaps, of the participants. Maybe there is a variation there. It feels like atropine, certainly the 0.01%, it feels like atropine is still we're not 100% certain. I think there's fairly good evidence on the higher concentrations, so the 0.25 and the 0.5%. And I think at the moment, until we get some really strong data, most clinicians seem to be leaning towards that slightly higher concentration and perhaps leaving the 0.01% just to the sideline and let's wait and see. Again, the big controversy with atropine, of course, is if it's being compounded, you sometimes maybe don't even know what you've got. And it may vary from one bottle to the next. There was a study, again, presented at the Academy. There was some work on what was in the bottle, and some pharmacists are diluting with saline. Some are using 1% atropine and diluting it. Some are using a powdered atropine and then adding a vehicle. And so we don't really have a standardized commercially available atropine that we can trust as being the same month over month over month. So I think until we get to that stage, we might be, you know, just a little unsure of what we're actually giving to our patients.
Well, that's definitely a fair point, and I think that's understandable. I would say from my perspective, I've been doing a lot of 0.05. I know that's, I guess, on the stronger side, but to just sort of not have the risk of, you know, like with the 0.01 being a bit of a gray area right now, I think that's something that's been beneficial as far as I've seen results from our patients. But I'm curious to see about long term now, you know, and I'm starting to hear some word on the street about rebound effects and things like that. Again, not sure if that's just about 0.01 or the 0.05 as well.
Yeah. And again, you know, rebound was something that was talked about in the original studies and is still being looked at. I heard something at Academy to say there was no rebound. I don't know. I don't know how long you can keep a patient on atropine. I mean, it is a drug. It is a, you know, potent drug. And what impact does it have long term? I think the majority of people use it as a introductory option, maybe for your younger patients, or they use it as an adjunct initially if perhaps they have a fast progressor, and then eventually look to take the atropine off. But we don't really have a standardized way of managing patients. We don't have a formula that you plug in and say, this is what I've got, so this is what I should do.
Yeah, and that's part of the difficulty, I think, or maybe the what maybe intimidates some practitioners right now is that there's no standard protocol that says here's step 1, 2, 3 on how you should treat patients, you know, like we do with glaucoma, for example, or other conditions. So certainly that is something that I think certain colleagues don't want to dive in until they have that written down. They don't want to experiment, so to speak. But hopefully in this conversation, we can kind of lay out a little bit of groundwork for our friends and colleagues who are listening. Let's switch gears to the education side. You know, you mentioned there's a few different things that you're doing in your day-to-day work, research, you're clinical, you're seeing patients, but you're also educating. You're an educator. So I'd love to hear what that looks like as you're training the next generation, you know, the future generations of optometrists. You know, I know it's probably because you're involved at different stages along the way, second year, third year, fourth year, and so on.
Mhm.
If you don't mind, kind of what does it look like? What's your level of involvement at each step?
So my main role, majority of my teaching time is spent in the clinic with fourth year students. So I work with groups of students in the pediatric clinic. So obviously we're seeing pediatric clinic is kind of up to about 8, 9-ish, 10-ish. I mean, it just depends on the patient. If we've been following a patient, they sometimes stay with us a little longer before we punt them into the main primary care clinic. But I'm working with children and with students, and obviously educating them on the best management and the evidence-based management of those patients. I also work in the clinical techniques lab. So I'm currently teaching a second year lab. So some basic clinical techniques, trial frame refraction, for example. We're really making sure their retinoscopy skills are good, and then we're doing cover tests and things like that. So I get the opportunity to talk about prescribing for patients and, you know, different aspects of managing patients. So I try to bring it into the real world rather than here's how you do a cover test and, you know, here's how you do this. Try and actually make it relevant for them. And then in the winter term, so come January, I'll be teaching on the pediatrics course. So that's the didactic course of pediatrics. And of course, you know, we talk about management of refractive error, and naturally we talk about myopia control in that course as well. So I do case examples, a lot of case-based teaching so that they can really get to grips with, when you have this patient in the chair, what are you going to do? What are your options?
That's great. So would you, so now the students that are coming out of Waterloo, at least, I don't know, obviously we can't speak for other schools here, but are they coming out with this, they're ready to just jump in on myopia management? For the most part, they should have at least a foundational
They
level
should
of
be.
education. Yeah.
Yeah, they should be. What's interesting is in our fourth year, we have a third of the students on site at any one time, and 2/3 are out on their clerkships. So of course, come the fall term, I get a group back that have already been out in the spring term.
Right.
And even though their knowledge is evidence-based and up to date, what they did in the practice they were working in isn't necessarily the same. So it's very interesting when they come back and say, oh, we didn't do myopia management, or the doctor I worked with didn't think that this was a good option. So we didn't really do that. So that's interesting. And obviously, as an intern, it's hard to impart their influence on the practice.
Right,
I mean, they're there to do their training, but hopefully, then when they graduate and even if they join another practice, they have the option then to perhaps find an area where they can impart their knowledge and share what they know that's the current evidence with practitioners that perhaps not quite as current.
I think that's a good point. And I would say, I think in most cases, I mean, I can't obviously speak for everybody here, but I think the you know, the owner of the practice or the head of the clinic that they're going to as part of their externship, I think they would usually be open to hearing, you know, from students in fourth year, because they know that what the students are learning is probably the most recent information. I know that from my own experience, I had certain preceptors or owners of the clinics actually ask me, okay, what are they teaching about this, or you know, how do you use this? So you know, I would say that to students, you know, feel comfortable, feel confident in just mentioning it to the, you know, obviously with a bit of humility, mentioning it to the clinic person who's running the clinic, and they might be open to hearing it.
Yeah, absolutely. And some clinics are. I think some students are a little more confident and others are a little more reserved. So perhaps don't feel that they can share their knowledge, although I think they have a lot to share.
Absolutely. We are actually going to be, our office is going to be a clinical site starting next year. So next year's our first year doing that. And I know certainly I'm getting a little nervous. Like, is my level of education or clinical skills up to what the students are going to know when they're coming in? So I'm going to be asking them some questions for sure.
You'll have to give me feedback as to what you think.
Well, it won't, they're not from Waterloo, but I'll still give you some input. I'll still give you some input on, you know, what the what the students are, how they
Yeah.
are.
Yeah.
It's gonna take us some time to get ready to see students and have them be busy and seeing the patients and
Hmm.
getting the full clinical experience. There's something else you said in there, Debbie, that I think was I wanted to just go back to. And when I was in school, now it's been a lot of years, but I remember, I think in first year even, one of the professors said, if there's one tool, if there's one skill that you should absolutely learn, first, I think he posed the question, what do you think it would be? And, we might have said ophthalmoscopy or using a direct ophthalmoscope. And he said the number one thing is retinoscopy, like bar
Hmm.
none, no matter what, learn retinoscopy and know it well, because there's so much information that you can get
Yeah.
just from doing good ret. I just wanted to share that with you and get your thoughts on that.
Oh, you can get me talking about this all day. I think retinoscopy is so important, and I'm so sad that it seems to be a lost art. So again, when students come back, I'll often say to them, so how much ret did you do while you were on your clerkship? And they look and they go, not much,
Ah,
or
yeah.
oh, none. It's so important, particularly with children, particularly
Oh
with
yeah.
young children. I mean, I'm a little bit more open to autorefraction on kiddies now than I perhaps was. I was a little bit of a dinosaur that, ret is the way to go, but
Yeah.
I'm fine with using autorefraction in the right situation. But I still think retinoscopy gives you so much information,
Hmm.
and is so valuable that it does feel like it's becoming a lost art.
Yeah. Well, I'm glad to hear you say that, because it's something that I certainly use every single day, with a lot of, not just kids. If I'm having a little trouble with the refraction, things are not quite adding up, you do ret, and interestingly enough, almost always you find something a little different than what you thought. And with kids across the board, all the way through, till they're probably 18 years old, I'm doing ret on pretty much every child.
Yeah.
But it took me until I was practicing, probably 5 years or so into my, career, that I realized how true that statement was and how valuable it is. So I'm going to make sure that, just so you know, when students come to my office, I'm going to make sure that they're doing ret
Would
on
be
as
it.
many people as they can, so they're leaving with that skill. Truly valuable.
Even things like lens opacities,
Yeah.
keratoconus, you can pick them up on ret way earlier than you can pick them up on other things, or at least it gives you a sense of what's going on. So yeah,
Yep.
it's more than just refraction, and it really is something that I certainly encourage the students to do ret on absolutely everybody, at least just to get good at it.
What's up, everybody? I just want to take a second to thank our partner for this episode, Hoya Vision Care Canada. Hoya's MyoSmart lenses offer exceptional performance backed by compelling evidence demonstrating their high efficacy and long-term sustained treatment effect, with an average change of less than 1 diopter over a 6-year period without any rebound effect. MyoSmart's robust clinical evidence answers all your questions with over 25 publications from across the globe, so you can confidently manage myopia in your everyday practice. In addition to the wealth of clinical data, what sets MyoSmart lenses apart is their integration of patented award-winning DIMS technology with photochromic and polarized solutions, offering a comprehensive portfolio that allows you to customize your recommendations to suit your patient's specific needs, ensuring they can enjoy life to the fullest by seeing more clearly. The versatile MyoSmart lens portfolio stands out in the industry, and it's bolstered by a robust body of evidence you can trust. That's confidence through evidence, and that is MyoSmart. Experience the future of eye care today and reach out to your Hoya representative, or go to www.hoyavision.ca to learn more. And now, back to this episode. Yeah. So on that note, the next question I was going to ask you was, since we're talking about education and we're talking about students, if there's students listening to this episode right now, is there anything that you'd like to share with them about clinical practice, any pearls that you think will be helpful for them when they get out into the real world? Now,
Ooh.
I guess the second thing, the first thing is do retinoscopy. What's the next thing?
Yes, retinoscopy. Yeah, just keep up to date with the evidence as much as you can. It's really hard because, of course, I'm focused on myopia and children, which is easy for me, but I'm in a bit of a silo. When they go into practice, they're also dealing with glaucoma and, anterior seg issues and contact lens fitting. And so they really do have a very broad, need to have a broad knowledge base, obviously. So I'm very conscious that it's hard to be good at absolutely everything, but at least do your best and stay as up to date as you can, so that you are offering your patients the best that you can. And the patients deserve that. They deserve to have the best treatment possible, whether it's glaucoma or a bacterial conjunctivitis or myopia or, you know, a BV issue. They deserve the best.
Absolutely. Now, one of the things that we put a pin in earlier was what's happening in practice right now,
Mhm.
myopia practice. So existing practitioners, and you were saying there's some research been done and you have some preliminary information. One of the questions I like to ask experts in the space, yourself and others that I've spoken to who I know are practicing myopia management at a very high level, um, or are really involved in kind of understanding the population, is, you know, how many practitioners, you know, across North America, or if you want to keep it to just Canada, what percentage of practitioners are actually practicing myopia management right now?
Not enough
Yeah, sure.
is the first answer. So the preliminary data we have, so this is a research study that actually came out of the American Academy of Optometry fellows doing research. So we have a group of practitioners. So apart from myself, everybody else is in clinical practice. And then we have a mentor. We have Robin Chalmers, who's our mentor from the Academy. We have a postdoc working with us who's been doing all of the legwork on actually analyzing or inputting the data and analyzing the data. And we basically looked to go into just regular practices. We didn't pre-select. They just had to see children and allow us access to their files. And so we're picking 5 files from age 6, 7, 8, 9, 10, 11 on pre-myopes and myopes over a 5-year period. So we have 5, 6-year-olds in 2017, 2018, 19, and so on. So for each age group. So it's a massive data set. We've done the analysis of 7 practices. So it's a, you know, kind of a snapshot. We're looking to do 15 to 20 practices, but the preliminary analysis has been on 7. And depressingly, 60% of myopes are being managed with single vision spectacles across the board. That's in general. Now, some practices are different, obviously. And I was talking to somebody at the Academy, and he was adamant. He's like, I don't do that. I'm like, I get it.
Of course.
You know, okay, I understand. But when we average it out,
Yeah.
60% across all of those years, including up to 2021, are prescribing single vision spectacles. About 30% are monitoring. Now, you know, I can understand if you've got a minus half diopter myope, you might monitor and wait, but there's a lot of people monitoring. And then we have about 10 to 15% that are active in myopia management across all aspects. So contact lenses, spectacles. Of course, we saw a really nice spike when spectacles were introduced into, this is Ontario practices, and a little bit of an uptick when contact lenses were introduced. So trending in the right direction, but still at the very bottom of the scale, still a very low percentage. We also looked at conversations. So when are you having the conversation with patients, parents about myopia management? And encouragingly, the refractive error is going down when the conversation starts.
Oh, that's good.
So more people are having the conversation at a lower refractive error. And the other piece we looked at is the pre-myopes, which of course really are the patients we want to encompass, like straight away, those young, low hyperopes that are on that trajectory towards myopia. And again, encouragingly, lifestyle changes are being discussed quite early on with those patients. So low refractive errors, there's an increase in lifestyle discussions. So very encouraging, but still disappointing. I mean, a lot of work to be done, even to get to the 50% mark. I mean, we're looking at 10 to 15% of those practitioners actually managing the myopic patients the way the evidence tells us we should be.
10 to 15. So interestingly, that number seems fairly, I would say 10% maybe seems fairly consistent with when I've asked people in the US and involved in different areas of the industry. they would
Yep.
say maybe around 10%, which is surprisingly low. I
Hmm.
suppose it would, if we wanted to be optimistic or whatever about that, that means we have a lot of opportunity and there's a lot of low hanging fruit for us to kind of
Yeah.
jump on and grab on. And,
Yeah.
great chance for many of our colleagues to get in there as quickly as we can. And like you said, we're lucky in Canada to have spectacle options, and we have now for a few years, that friends in the US don't have sadly yet,
Hmm.
but hopefully they'll get soon. The pre-myope conversation is interesting because, when I give a lecture on myopia management, I like to do a little bit of self-promotion here. I say it's called the Myopia Startup. So if you ever see that listed on a lecture when you go to a conference, come check it out. So it's called the Myopia Startup for a reason, because it's like entry level. Let's get started. How do we get into this? And one of the questions I ask the audience is, are you willing to have a conversation with a parent whose child is a plus 50 or a plus 75? Would you consider that child as being part of myopia management? And the answer should be yes.
Hmm.
Of course, if we've been tracking their changes, if we've been tracking axial length and we're seeing a trend in that direction, then certainly that should be a child that we are looking at least having a conversation with. But we just want to get as many of our colleagues comfortable having those conversations.
And it also kind of begs the question as to why you wouldn't have that conversation. You know there's a risk factor, parental myopia in particular, and we know that that low amount of hyperopia in young children is indicative. So why not have the conversation? And the conversation is simple. It's actually what parents want you to say. It's
That's
more
true.
time outside, less times on screens.
Yeah.
How many times in a week do parents say to me, "Oh, doctor, can you tell him that needs to stop playing his iPad?" And I'm like,
Yeah.
okay, I'll be the parent here, and you
Yeah.
sit them down and you say, okay, buddy, you've got to start. Well, he likes to play on it all day. I'm like,
Yeah.
okay, well,
Daily
so
conversation. Yeah.
yeah, you need to have that conversation. I sometimes, and in some of my lectures, you might see, or I certainly talk to the students about, every child is on the myopia platform. So if we think about a train station, every child is on the platform. Some children get on the myopia train and some children stay on the platform. And the goal is to keep them on the platform as long as possible. And then when they get on the train, some are on the slow train and some are on the bullet train.
Oh, yeah.
So we want to keep them on the slow train. Once they're on that train, they're not getting off. So once they're a half diopter myope, they're not getting back on the platform. They're not a pre-myope anymore, but let's slow it down as much as we possibly can. So it's just what we should be doing. And again, we have so much evidence that we really have no excuse. And you mentioned about axial length change. I mean, that's a whole different conversation. And that has not become standard of care yet. And I'm not sure when it will. I think you have the very active practitioners, although, I was talking to this one particular practitioner that said to me, "Oh, that's not what I do. I manage all my myopes," but he didn't measure axial length. He doesn't have an option to measure axial length. Doesn't mean he's not managing his patients well, but he perhaps is missing some of the subtleties, maybe in those pre-myopes where the axial length shift changes before the refraction. So, if we were actually creating a menu of things that you should be doing, I think axial length on all children might be there. We're not there yet, and I don't know that we ever will be, perhaps until we get something portable and easy and cheap to measure axial length. But it would be very interesting to monitor axial length change alongside refractive error, even in those pre-myopes.
That's great. First of all, I love that analogy, the platform and the train. That's a really great analogy. Very cool. And the fact that there's slow moving trains and fast trains as well. That's really great. Now, on the point of axial length, that actually was going to be one of the next questions I wanted to ask you. The idea of having a portable device or something small and small footprint, easy to use, I think that's actually a really good point. And I'm wondering if there's any companies out there racing to bring that out, because I think that will be a successful product to have. For the practitioners who are sort of early in the game here, just getting started in myopia management, do you think axial length is imperative on day one, or should they work towards that and maybe add that into their arsenal at some point down the road?
I think it's ideal, but it's not imperative. Nobody should hold back from managing myopic patients if they can't measure axial length. If they can get somebody else to measure the axial length, great. So I know clinicians that have local ophthalmologists that will happily measure the axial length for their patients. So if you've got that option, if you don't have an option, if you're looking at the evidence, and we're circling back to one of the very first things we talked about, if you're looking at the evidence where there's a good correlation between axial length change and refractive error change, then you can kind of trust the data. You trust that somebody else did all the hard work.
Yeah.
They saw all of the participants, they took all the measurements, and if the correlation is there for that particular product, you can probably be confident.
Right.
Again, comes back to if there's a new product on the market and somebody comes into you and says, hey, this is the one you need to be using, just make sure there's good correlations. So yes, go ahead and start even without being able to measure axial length. To your question about a portable device, there is actually one that's being launched early next year. It's a company out of the UK. I've seen pictures of it. I haven't touched it. I'm desperate to get hold of one. I'm really hoping that they're going to send me one.
Yeah.
And I think it's going to be at a price point that's going to be manageable. With that said, some of the other instruments, the multifunction instruments, I think at a higher price point can give you so much value when you're able to do other things. So you might be able to do auto refraction with one. There's contact lens fitting options, topography, keratometry, the printouts that parents get. I mean, parents love to get reports for their kids and, you know, can see if they're monitoring over time and see if they're still on that same percentile or whether they've dropped down to a different percentile. So
Right.
I think there's value in those multifunction instruments. And if somebody's looking to invest in their practice, perhaps that's where they want to look so that they get an advantage, a small footprint, and they're getting multiple options from that particular piece of instrumentation.
Yeah, that's a great point, actually. So for our colleagues here in BC, of course, I'm not sure how it is across the country, but here our provincial health insurance, which we call MSP, our association, the BCDO, has done an incredible job. I always want to give them as kudos whenever I can to negotiate a new agreement with the government to get new billing for us through our provincial government now, and they've come up with a new billing code for axial length, actually.
Wow.
So if we have a child and we are suspecting potentially myopic progression, and there's, you know, a little bit of a gray area or, you know, honor system on that, but we do axial length, we can bill a certain number of dollars, and I think that's going to help encourage more colleagues here in BC to kind of get into it, invest in the device, because you'll be able to make that money back, whether you're just billing the government or you come up with your own consultation fees. You know, hopefully that'll help us get more into it.
Yeah, I mean, we don't have that luxury in Ontario, but we do bill the patients, and parents will pay that little bit extra when you explain why it's important. They will pay for that service.
Yeah, that's great. And I've spoken to a couple other colleagues who they do a full suite of tests. I think it's a great idea. So they have the consultation fee, whatever that number is, the topography and axial length and the cyclo and even maybe wide field imaging, you know, Optomap or something like that, just to kind of get that in there. I think that's all a great idea.
Yeah, I've heard the same thing. It's a fixed fee, and for that you get all of these clinical techniques done, and you get the clinical testing, and you get the results, and then the practitioner and the patient has a good sense of where they are, certainly where they're starting from.
That's great. That's great. You touched on this briefly earlier when we were talking about atropine, but the idea of doing an adjunct or a combination of therapies. I know it's a gray area and we don't have protocol set, but is there sort of at least an idea of when doing a combination might be a good idea? Let's say spectacle plus atropine. Is it something that is there a lot of data showing it's useful, or?
There is not a lot of data. I mean, there is some data, but it's not that strong. Seems to be more of an impact in the first 6 months or so. So if you introduce atropine as an adjunct therapy early on, perhaps there's a little bit more of an impact. One of the things I think is valuable, because atropine, I mean, it doesn't really matter how it acts, but it acts in a slightly different way. There could be an argument that you're hitting things from like two aspects. But the other thing for me is, particularly for those spectacle wearers, is you've got coverage kind of at all times. So spectacle wearers are not necessarily the most compliant with their spectacles. So the low myopes we really struggle with, because if you're an 0.75 myope and you're 7, You know, there is no incentive for you to wear your spectacles at all.
Yeah.
You might put them on when you get to school, as soon as they come off for recess, or, you know, you have gym class or something, they're off, and chances are they're in the backpack and they don't go back on. So
Yeah.
I think if you've got an adjunct therapy, at least you've got coverage in both sides. Now, you could say, well, why don't you just do atropine and not spectacles? Well, if they need a vision correction, why not put them in a myopia control spectacle?
Right.
I think there's no reason not to. I mean, this, you know, 60% putting in single vision spectacles is quite frankly ridiculous, because we have spectacles from different manufacturers that work, that children tolerate. They're cosmetically fine. You know, there's no issues with them cosmetically. Kids just wear them and they can see. So it's a no-brainer. You know, why wouldn't you do that? So I think, you know, adjunct therapies for spectacle wearers. Some people I know, when they see progression that they perhaps think is a little higher than they might expect, will add in an adjunct therapy. And again, no good evidence, but I think you're doing no harm, and you could potentially be doing some good.
Yeah.
So again, we need a lot more data, but all of these studies need to be long-term, you know, minimum of 2 years of data. And I think we're seeing more and more things being published now, but we've got a long way to go until we see the data hitting the journals and can be able to kind of pull it apart and really see what's going on with those adjunct therapies.
Right, right. So those of us who are into it, I think we just got to watch closely over the next couple of years. We'll start to get a lot of that information.
I agree. Yeah, absolutely.
Great. Well, the last question I have for you is, now we did a little bit of advice for students. I'd love if you could share some advice for practitioners right now on how to get started, you know, whether it's speaking to parents or bringing products into their practice, or however you might think is a good way for our colleagues to get into this.
For those that are not doing anything, I think you need to familiarize yourself with why you should be doing it and what's available and what the options are. So there's lots of great resources out there. I mean, there's podcasts such as this. What a great resource that is. There are things like Myopia Profile, which is a very clinician-friendly website out of Australia. You've got Review of Myopia Management. You've got the International Myopia Institute papers. So you can pitch it however scientific or kind of more grassroots that you want, but there's lots and lots of information. It's in every CE meeting. So you'd really have to have your head in the sand if you're not able to access some information, and just do it. Just actually take the plunge. We have products available. We have contact lenses. We have spectacles. If you're not sure about atropine, because maybe you're not sure about the compounding pharmacy that's closest to you, or you're just not, you know, not really sure about that, that's fine. You don't have to do that. You don't have to do ortho-K. You don't have to be able to do everything to manage your patients. Parents are beginning to ask. So I have patients that come in and straight away they know what they want. So parents are becoming more interested and more informed, and it doesn't take much for one parent to tell another. And if you're not doing it, they're going to go somewhere else. So you are going to lose your patients. And again, I'm circling back to what I've said before. Your patients deserve it. You should be doing the best for them. And we know that that is the best option. So take the plunge. Get some products in, get used to fitting those spectacles, get used to offering them. And I think practitioners sometimes say, well, I don't know how to have the conversation with the parent. It's easy. You tell them that by slowing down the rate of progression, you are going to keep those eyes as healthy as possible for as long as possible. What I also say is, of course, better uncorrected acuity. So, you know, if they're in the swimming pool or first thing in the morning, you know, a -2 myope can manage much better than a -4. And better options for laser vision correction. That one resonates.
That one does, yeah.
With parents. Better options for laser vision correction later on. So those are my 3 reasons. And then you give them the options. And if the only option you have is a spectacle option, then that's what you recommend. If you have spectacles and contact lenses, then you give them the choice and you explain the differences. If you have all the options, you can discuss all the options, but it isn't difficult. You don't have to go into the complexities of the optics of contact lenses or spectacles. I actually just say, there's a special type of spectacle lens that has been shown to slow down the progression of myopia. There's a particular type of contact lens that has been shown to slow down the progression. There are drops that have been, and it's the same message every time. And they came to you for their child's care for a reason. It's because they trust you. And so they're going to trust your recommendation. Otherwise, they wouldn't be in the chair to start with. People don't take their children to people they don't trust.
That's a good point.
So you are the caregiver. You are providing optometric care to that patient, and they are wanting the best option for their child.
That's great. Great advice. Thank you very much. If I could just add something about, I feel like to what you're just saying about, sometimes colleagues, practitioners may not feel so confident in offering. They don't know what to offer or whether it's going to work. A guest that I had on my podcast early in the kind of the journey here, who was a football player, and he was talking about how do you get confidence in something, in anything, whether it's playing football or practicing optometry. The only way to do it, the only way to get confidence is by just doing it, like you just said. And then you get the feedback, you get the proof that it works. And that's the confidence that you have then to go further in. But you have to start. That's the only way.
Yeah, absolutely. And you do see the results. So when the patient comes back, 3 or 6 months later, and you see that there's been no change, and the parent, because the parents sit on the edge of the chair, they're just desperate, they're waiting. And then you say there's no change. It's like a hallelujah moment for the parent and for you. It's like, wow, great. See you in 6 months. Fabulous. Off you go. So yeah, do it. See the results in the same way as when you first started treating glaucoma or anterior uveitis. I mean, you did what you were told to do, and then you had the patient back, and it's like, oh, look at that, the pressure's lower, or oh, look at that, it's cleared up. I mean, we treat things, and this is treating myopia. This is slowing down progression using a treatment modality, and you will see the results.
Absolutely. Absolutely. Thank you so much, Debbie. I really appreciate you having on the podcast. Having you on the podcast. There's so much value in this. I hope, if you have time, go back and listen to some of the things that Debbie was sharing in here, because there's going to be a lot in there for you to digest, but really great information, whether you're looking at from the research perspective or getting started in practice wise. Thank you so much for sharing all of that information. Any final words you want to share before we wrap up?
I think just do it. I think that, that's somebody else's tagline, but we can use it here, we're not
we got to be careful. We don't want to have to pay royalties.
Well, exactly. But yes, maybe just do it now. There we go. Now on the end.
Yeah. Thank you so much. Thank you very much, Debbie. And I want to say thank you to Hoya Vision Care Canada for sponsoring this episode. This is one of 4 episodes in a series of myopia management that we are producing here on the 2020 podcast. So thank you to Hoya Vision Care Canada for their support in that. And thank you to everybody who's listening, watching, and supporting the podcast. This is the 2020 podcast, Canada's #1 optometry podcast. I will see you guys in the next episode.